You guys hear me? Is this on? You're hearing me come through? Awesome. Well, good morning. Let me first say thank you because I heard that patient assessment got out a little early today, and so you stuck around, so thank you. I appreciate that. Do what? Just for you. Oh, thank you. I appreciate it, Kayla. Thank you. I feel the love. I feel the love. So I will be here for all 2 hours today. Dr. Fast will be here on Friday to go over the med-chem portion of what we're discussing on the pharmacology in this section. So I'm here for the whole 2 hours. I think there were some questions about if my part is on the next exam. It is. Be sure that you look in the syllabus and you can see the breakdown there. We're going to do some fun stuff today. We've got some social media stuff I'm going to throw in. We're going to do a back channel. If you don't know what a back channel is, you're going to learn today. So it'll be fun and engaging, I promise. Let's see. Dr. Davis is here today. He's not here to watch you guys. He's here to watch me. Okay, so as a part of our evaluation process, as we develop as teachers, we have peers come in and give us feedback on what we're doing. So he's here to watch me today. He's not here monitoring you as the course sequence or the sequence coordinator. He's here for me, not for you. But at the end of today, I will go ahead and have you guys do my evaluation form. The official one from the school, so I'll leave early so that you can do that because this will be the last time I see you this semester, but next semester I'll see you a lot. So, plus I see you every exam anyway, so. But this will be the last lecture hour that I'm with you. So I have a couple of review questions for you. These might be a little bit more difficult than the ones that we did before, so why don't you talk about these with a partner, okay? You like that? Yes. See, I'm proving that you haven't just memorized a drug name, but you've actually memorized how it works and what the mechanism means. So, yep, I've made up a new drug, Casilamide. One, two, three. Okay, you've got about 15 more seconds to come up with your answer choice. Three, two, and one. Okay, so we're going to do this with a show of fingers. Okay, so on the count of three, just do 1, 2, 3, or 4. And remember, this is 3, not W. All right? Okay, ready? 1, 2, 3, go. Okay, we've got a good mix here. This is going to be a good discussion. Okay, so let's work it out. I'm really seeing 1 and 4 as being the options here. So let's go through. It has effects on both SA nodal cells and ventricular myocytes. So the SA nodal cells, it's decreasing the slope of phase 4. So the slow phase 4, what current is that being carried by? It's our funny current. Sodium, okay, so I'm thinking sodium here. But in ventricular myocytes, it's decreasing phase 0, which is your straight upshoot. What is that being carried by? Ooh. Ventricular myocytes, it is sodium, okay? So in ventricular myocytes, it's phase 0 upstroke, which is also carried by sodium. So we've just said sodium and sodium. Phase 2 and 3 of the ventricular myocyte action potential is not altered. What's phase 2 mostly carried by? That's your plateau. Calcium and potassium starting to come in play, and then phase 3 is potassium. So now, after working through that, I'm going to give you a chance to change your answers. So on the count of 3, give me numbers again. 1, 2, 3. Okay, so number 1 is the sodium channels. We said that was the first thing that should come to mind. Yes, I agree. Class 1 would be what we're looking for here. So the slide that I would come back to think through is class 1 or sodium channel blockers, because it's the first thing you think of. We said B is the second letter of the alphabet, so it's easy to remember that one. Class 3 is mostly what type of channel blocker? Potassium. And then calcium channel blockers would be the last one for 4. So we're going to dig in deep to these today. We've gone over broadly the mechanisms, but we're going to hop into the drugs at this point. But I do want to say here that class 1 and class 3, those are if we're trying to convert someone out of an arrhythmia. Okay, like we want to try to get rid of it and see if we can maintain them in normal sinus rhythm. Now, some of those drugs can be used for maintenance therapy as well, but mostly we're using those to actually convert someone from the arrhythmia. Whereas class 2 and class 4, so I'm going to put conversion here because that's usually our goal when we're using these drugs. But class 2 and 4, this is usually maintenance therapy. We're calling it rate. Actually, you know what? I'm going to go back. Let's call this rate control altogether. So this is rate control. Oh, went too far. So rate control will be what we're trying to do with beta blockers and calcium channel blockers. We're not necessarily getting rid of the arrhythmia. We're going to live with it. But what we're going to try to do is make sure that that AV node is strong so that even though we might have some type of arrhythmia going on in the atria, it's not making its way to the ventricle, because we know that ventricular arrhythmias are life-threatening. So for beta blockers, calcium channel blockers, and also DIGs, remember we said digoxin is not in the classification system. It's kind of outside of it. That's one of the disadvantages of Vaughan Williams. But digoxin also does rate control. So calcium channel blockers, beta blockers, and digoxin are going to be, we live with the arrhythmia, but we're controlling the rate so that people aren't feeling that fast heartbeat or palpitations from the arrhythmia. Cool. Got one more question for you. Again, discuss this one with a partner. Give you about 30 seconds for this one. Fifteen seconds remaining. Three, 2, and 1. So even though it's A, B, C, and D here, we'll still hold up fingers. Give me 1, 2, 3, or 4 for your answer choices here. Ready? Go. Oh, wow, we are all mixed here. I even see some 6s in the group. So we're getting creative here for sure. Look back at this one. In fact, what I'm going to do is I've been giving you practice questions throughout, and I know you're taking pictures and, trying to keep up with them. I'm just going to post a document for you. How about that? I'll post. You're welcome. I'll post some practice questions for you that are all of these that we've done in class, plus a couple of extra just for you to look at to get ready for the exam. But B would be the correct answer here. We're correctly matching the arrhythmia to what's actually going on. So ventricular fibrillation, is that one that we can live with, or is that life-threatening? Yeah, definitely life-threatening. All right. So now we're hopping into the individual agents. We spent the last couple of minutes of class on Monday going through the learning objectives, so I'm not going to hit them again here. But remember that kind of the big portion of this is probably this third bullet point. I'm going to point these out to you in those tables as we get to them, but definitely work through this. This is where my questions will come from for the exam. We also looked at this table and joked about how you do not have to memorize every single plus sign or up and down arrow here, but as we go over those drugs, we'll come back to this table and see how it makes sense as far as how that drug is affecting the different parts of the EKG. So first up are sodium channel blockers. So anyone hungry yet? Still a little early, but you guys had an early morning, so you might be ready for lunch. We are going to break down sodium, which obviously is in this type of food, right? So our sodium channel blockers, we are going to use an acronym with the double quarter pounder to help you remember the different subcategories. Because remember, we're calling them sodium channel blockers, but there's actually 1A, 1B, and 1C. And you've got to keep those straight because they act differently. Now, before we hop into it, we need to talk a little bit about sodium channels and remind you of a few things from Patho. So let's focus just on this top figure here. So just the top part. Remember that there's really 3 different phases of a sodium channel that it goes through. This dotted line at the bottom, which would be at diastole, or which phase of the action potential? The dotted line at the bottom, what phase is that? Phase 4, because we're on a ventricular myocyte. So that is when the channel is at rest. It's ready to be activated, blocked, whatever the instance is. It's ready for action. Now, on the upstroke, this is a ventricular myocyte. So what phase is this upstroke? 0. This is phase 0. We know it's carried by sodium. This is when the channel is open because sodium is moving in or moving out of the cell? Moving in. So sodium in at this point. So the channel is open and activated. But once it reaches phase 1, phase 2, and phase 3, you'll see that it's blue. It's inactivated. We used the analogy last year of a toilet. When you flush the toilet, you flushed it that first time and you realize, need to flush again. You can't flush again, right? Like nothing happens when you hit the handle. The toilet isn't activated at that point. You have to wait for the water to come back up and fill, and then it can be activated again, right? So think of the blue line here as being that inactivation. Even though another stimulus is coming through, it's not likely to open. The channel is inactive at that point. So drugs, usually when we're talking about sodium channel blockers, they are going to bind to the open or an activated state. They really don't like the resting state. Okay, so when they're binding either in the open or the inactivated state. So when we get back down to phase 4 or the diastole, usually we should have recovery at that point. So each diastolic period, the drug normally dissociates from the channel and the block is relieved. So that's your second bullet point there. And that's what we're seeing in the bottom part of this figure. When the channel is open, there's a blockade. And even when it's inactivated, there's still part of a blockade. But when we start coming back down to diastole, then our block starts to go down. And so there's not as much blockade on the channels. Now there's 2 caveats, and that's what's shown here in the middle panel and in the right panel. There's going to be some drugs that just stick to the channel for longer. They have really slow dissociation kinetics. So that's what you see there in that middle panel. So there's more blockade because the drug's just sitting there longer. It's not dissociating when the channel is at rest. And then the second caveat would be when your heart rate is increased, then you're going to have more of a block on those sodium channels as well. And you can just see it's just a building block because it doesn't have time to get all the way back down to resting or to that diastole period because the next heartbeat started immediately. So we're at a block again. So it never fully gets down to that resting period, so you have more of a high blockade. That's what causes some of the problems with sodium channel blockers. Okay, So you need to have this figure in your mind when we're talking about the different classes. We're going to zoom in first and just talk about class 1A. And you know that sodium, when we're looking at a ventricular myocyte, we're really looking at phase 0, which is here. So when we block that channel, and class 1A agents have what we call a moderate sodium channel block. It's pretty good. So it moves that curved line down. And so our upstroke for phase 0 is not as sharp. So it's taking a little bit longer. But there's something else that's different about class 1. Prolonged repolarization. Which ion is typically responsible for repolarization? Potassium. But I just told you that these are sodium channel blockers. Well, class 1A agents also have potassium blocking properties. Okay, so it's just a caveat. You just got to know the class 1A agents will also prolong repolarization. So that increases that effective refractory period that we talked about on Monday when another action potential is not going to come. So let's look at the drugs for 1A. Now I know this is really hard to see. That's why you have it in front of you. But what I want to do is point out key things from each of the tables. So let's look at the table because this is the first one that you're seeing. So I just want to orient you to the table in general. You've got your drugs listed on the left-hand column. So quinidine, procainamide, and disopyramide are the 1A agents. You're going to remember that by double quarter pounder. Your 1A agents are DQP, double quarter pounder. Okay, we're building our sandwich. This is the base of the sandwich. You've got the mechanism, which we have already gone over in depth on Monday, but you can read back over that and see how it relates to the notes that we've already talked about. But then your columns here are going to show you clinical application. So it's really what type of arrhythmias are these good in. You do not have to be an expert at arrhythmias, okay? Like I am a cardiovascular clinical pharmacist, and I usually don't treat arrhythmias. There is a whole electrophysiology team, at least where I've practiced, that takes care of arrhythmias. I want you to know the general basis of arrhythmias. So we'll come back to these and I'll say, you know, these are mostly atrial arrhythmias that these drugs treat, or these will do atrial and ventricular arrhythmias, or this one in particular will do torsades. So I'll point out the main ones for you. You don't have to remember every single type of arrhythmia. I want you to know the general concepts. Is it atrial, ventricular arrhythmias, or anything specific that I point out from there? Audrey?
So the mechanism mentions that it's blocking calcium channels, but it's in class 1 because like the main thing we're looking at is the sodium here.
That's right. So remember we said that the Von Williams, let me repeat that question. She said these also block potassium channels, which is true. That's how we get that effective refractory period, that elongation of the plateau. But their major mechanism is sodium channels. It's just that it bleeds into and also affects potassium channels. So a limitation of Von Williams is that these drugs aren't clean. They don't fit really nicely into one section or another. This is one of those examples, and it's just 1A that has properties of this, in this case, class 1 and class 3. Yep. So the next column is serious and common adverse effects. So your serious adverse effects are first in that very first paragraph, and you'll see it's italicized. You see in that difference. The serious ones are italicized. The common ones are in the second paragraph, but they're not italicized. So that's how you can tell the difference. And really, as pharmacists, you need to know both, right? You need to know those really serious ones to look out for, but you also need to tell the patients the most common things. So I'll go through and point out some of each, but this is going to be what it looks like in all of the tables moving forward. Contraindications are there. They will probably all make sense to you. And then therapeutic considerations are really pearls. There are some specific things about drugs or maybe a specific interaction that you need to look out for, but it's a really good summary to remind you of some specifics that go along with that drug. So that's what the table looks like. Any questions on the layout of the table? That's going to be what we look at for every single drug. All right.
Dr. Casper,
Yeah.
will you point out what we need to...
I am.
Okay.
I am. So now we're going to go in and actually talk about the drugs, and I'll point out the things that are specific. So quinidine here is really the prototype for this section. And if you notice, like on the adverse effects, it'll say same as quinidine, except maybe less of something or more of something. Quinidine is your prototype here. Honestly, we don't use this a lot. In fact, we use it more for malaria, if you have ever been to a place with malaria. But what we are trying to do here is a conversion. So it's usually AFib or aflutter, and we are converting it. So remember I said class 1 and class 3, those are the ones where we're trying to get rid of the arrhythmia, whereas class 2 and class 4, we're just trying to control the rate so that it doesn't get into the ventricles. So this is mostly for conversion. And these are mostly all atrial and ventricular arrhythmias. You can make that generalization for the whole class, that we're hitting both atrial and ventricular arrhythmias. Now remember, these affect potassium channels. So torsades is probably the most serious adverse effect here, because if we elongate phase 2, or that plateau phase, that effective refractory period, there's a big chance that we have prolonged the QT, which will lead to torsades. So we know that is life-threatening. We'll talk about how to treat that here in just a minute, but this is huge. Yeah.
Are all of class 1A, they're all going to be for AFib?
So the question is, all of class 1A, are they treating atrial and ventricular arrhythmias? Yes, you can make that generalization here. So torsades is a big thing that I want you to remember with this one. It's also going to cause some headache, lightheadedness. It's widening the QRS. Does that make sense? Yeah, because the QRS is the time that the ventricles are contracting, right? And we've just increased phase 2, or that plateau phase. So that should make sense to you. Now, it can cause some hypotension that we would watch out for. Diarrhea is actually in 30 to 50% of patients, so quite a bit to watch out for there. And there's some anticholinergic effects if you look through here. For the most part, anticholinergic, other than the diarrhea. Remember what anticholinergic is? Drying of everything, right? So basically diarrhea is the only one that doesn't fit well. It's also tachycardia with an anticholinergic effect.
Is the diarrhea
Audrey?
because the blocker is also hitting the electrolyte channels in the GI tract as well?
Absolutely. So they're not clean. She said, is it because we're hitting electrolyte channels within the GI tract as well? We are, because these aren't clean and just going straight to the heart, right? We are influencing these channels throughout the body. So look through some of the therapeutic considerations. Mostly it's going to be a long QT interval because we are putting the patient at risk of torsades by inhibiting potassium channels as well. A lot of drug interactions, you'll see this throughout. A lot of antiarrhythmics interact with other antiarrhythmics. So you've got to be really careful when you combine these drugs. And then this last one, agents that slow the AV nodal conduction, like beta blockers or calcium channel blockers, we already knew that. Those should actually be used in combination with quinidine because you will get a tachycardia from using these drugs. And so we probably will give a calcium channel blocker or a beta blocker to decrease that chance of tachycardia. So procainamide is next. You're going to see it's very similar. It mostly says same as quinidine, except less anticholinergic effects. So that's a good thing. But you should know that lupus-like syndrome occurs with this one if they've been using it for a while. It's really in about, again, 30% of patients can develop this lupus-like syndrome. The good thing is it'll go away if you stop the drug, so it is reversible, but it's something that we're watching for. Now, Dr. Davis is in the room, so let's see if we can make him proud. Have y'all talked about procainamide before in MedChem? And the acetylation? Maybe? No? So it gets acetylated in the liver to N-acetylprocainamide, which is actually an active metabolite that has real activity. So it has class 3 activity on its own. So another reason, if this drug, when it gets metabolized, it is active and has class 3 type properties. So you're even at more risk for torsades because we're lengthening that plateau period.
It's metabolized into what again?
It is metabolized into N-acetylprocainamide. N-acetylprocainamide, which is active.
That's class 3.
And that has class 3 activity. The active metabolite does. Yep. And disopyramide is really not used much, so we are not going to focus there. So in this section, look at quinidine and procainamide. We really don't use these agents much anymore. The class 3 agents have more replaced the class 1A agents because these do have some pretty nasty side effects, but you do need to be aware of them.
When you say class 3, do you mean?
When I say class 3, no, I don't mean 1C, I mean class 3. Vaughan Williams class 3 are potassium channel blockers. If I'm referring to 1C, I'll say 1A, 1B, or 1C. Yes.
So if we don't really use them anymore, what would be a case where we would use them? Like, why do we even still need to learn about them?
Yeah, why do we still need to learn about these if we don't use them much anymore? If patients are not responsive to other therapies, we will use them. Or if they have a contraindication to one of the other agents, we will still use them. So they are used, but more of a last line. Still got to know them. Okay, so now let's go into 1B agents.
Dr. Kassenbauer?
Yeah.
Just to make sure, there's no therapeutic concentration you want us to know for procainamide, right?
No, you don't have
Okay,
to know
all right.
therapeutic concentration. Nope. If you need to know that, like per guidelines or for a certain type of conversion of an
No, the
arrhythmia, then that would be
considerations on
Dr.
this-
Lamb.
Considerations on the slide.
Say it one more time.
Considerations on the
Oh,
slide.
considerations on the slide. So it's what I have already pointed out to you.
Okay.
Is that clear? Like the things that I've been highlighting and underlining.
We should know the last drug as well.
No, I said you didn't have to know the last drug because it's definitely not used as much as the other two. Yep. All right, let's look at 1B. Does it look much different from you? Does the dotted line look that much different from the regular full line? Not too much. So it has a mild blockade of sodium channels, so that's why we don't see too much of a change in phase 0 or the upstroke. And it does not prolong repolarization, so we're not as at risk of torsades or QT prolongation here. In fact, it might even shorten the repolarization period. So we've got lidocaine and mixeltine here. Phenytoin is sometimes used in kids, but I'm not holding you accountable for phenytoin here. But we had our double quarter pounder for class 1A, so now we are going to add lettuce, mayo, and pickles to our burger. Lettuce, mayo, and pickles are how you can remember this one. So lidocaine and mixeltine, it's good. They're basically the same thing, except lidocaine is available IV and the mixeltine is PO. So mixeltine is just the oral analog of lidocaine. Where do you know lidocaine from? Yeah, we think of it as more of an analgesic, anesthetic agent, not an antiarrhythmic, right? But sometimes we do use it for life-threatening arrhythmias. And this is for ventricular arrhythmias only. That's important. Really doesn't have too much of an effect on the SA and AV node. It's really trying to control any type of ventricular arrhythmia. So it would be life-threatening ventricular arrhythmias, usually in the context after an MI. So once someone has had a heart attack, you know that they are very much at risk of arrhythmias because that loss of gap junctions and connectivity. And so lidocaine is often given in that context. So some adverse effects that you need to be aware of are really neurological. So seizures are often the first adverse effect that we'll see. That's also over here in the therapeutic considerations. It's the first sign of toxicity. And that's because there is an active metabolite that builds up and affects sodium channels in the brain. And so we see seizures happen often here. Also, bradycardia is one to note as well. For more of the common side effects, tremor is present. Also add in nausea. But if you take with food, it'll decrease tremor and decrease the nausea. So that's a counseling point for the Mixeltine. Got to be careful with P450 inhibitors. So again, a lot of interactions with these two drugs as well. But we didn't talk anything about torsades here, did we? Or risk of QT prolongation. Why is that not a concern with 1B, but it was with 1A? Yeah, it shortened the repolarization period. If anything, it didn't have an effect on potassium channels. So again, we're not going to spend time on phenytoin. That is used more in kids. But focus here on your lettuce and your mayo. Not so much on the pickles. I'm not really a pickle person anyway. All right, so social media. Anybody use Instagram to learn pharmacy things? I do, and there's some really good cardiology people that I want to draw your attention to. I even put a extra document in the module section of our Canvas course to point out some of these people to you. These are some of my favorite pharmacists to follow. This is a cardiologist. This is a cardiothoracic anesthesiologist. So he talks a lot about these drugs because arrhythmias will often happen in surgery. Physician Doodles, I like her a lot because she will draw out ways that you can remember the drugs really well. And then AmCareRx gives some really good guideline summaries, or whenever new guidelines come out, he always makes you aware of those. And then the Consultant RX, he does a lot of evidence-based practice. And so I like all of these. I follow all of these. But I've picked some out. I kind of mark them as I come across them throughout the year. And this was one on lidocaine that I thought was interesting. So what I would like you to do is you can pull this up on Canvas or you can read it here on the screen. But we just talked about lidocaine. This is from the anesthesiologist, his take on lidocaine and when he uses it. So I'm going to give you about a minute to read through this post and then tell me some things that stand out to you about lidocaine. So you've got 1 minute. You don't have to focus too much on the concentrations. So you've probably read through it at this point. Anything kind of stand out to you about lidocaine? When does he like to use it? Yeah, so coronary cardiopulmonary bypass, or he calls it later CPB, because you're really using it for two reasons, right? they're really at risk of arrhythmias at that point because you've just been touching all over their heart, right? So they're at risk. But then it's also the anesthetic, and so it's kind of win-win. But he talks about how it is rapidly metabolized, and so it is ongoing metabolism in someone who has a good liver. And so he'll often use a drip in the ICU following use, and they're monitoring it, making sure that none of those adverse effects are happening. But this is how he is using lidocaine. So I thought it was interesting for you to see just a little bit of how it's really used in practice. So you can look back at some of those Instagram things. We'll bring a few up as we get to them. All right, so let's move on to 1C. 1C, you can see it has a really marked block on sodium channels. Now, it really doesn't do anything to repolarization. So phase 3 is about the same, but we have a really, really strong block of sodium channels. So with our burger, you have to have fries, right? So fries, please. That's what we'll add to this one because ecaniide is no longer on the market, and neither is morsazine. So flecainide and propafenone are the two that you need to know here. Flecainide, so I'll pronounce those are kind of hard to say. Flecainide and propafenone are the two agents here. You're not responsible for brand names, but if you've seen the brand names before, it's Tambicor for flecainide. You flick a tambourine. That's kind of how I remember that one, right? And it's rhythm. And then propafenone is Rhythmol, because we're trying to get them back into rhythm. You just have to know generic, but I think at least for some of the antiarrhythmic drugs, the brand name makes sense, and it kind of tells you what it does. So I like that. I appreciate it. All right, so things here is that these are mostly just used for atrial arrhythmias, or supraventricular might be the word that you see there. So it can be ventricular, but we're really using it more in the supraventricular. But note and star, this is if they are unresponsive to other measures. A couple of things that we want to look out for would be that these cause heart failure. There's a lot of kind of visual things that happen with these. Headache, dizziness, will even cause some syncope. So we're going to give these as an inpatient. We don't just give a prescription out and say, good luck, hope this works for you. We're going to make sure that they're not having any really bad adverse effects while they're in the hospital. So we give these as an inpatient first. But these are very much proarrhythmic. That's why we're watching them so closely, as they're likely to induce another type of arrhythmia. And star this pearl that they are associated with excessive mortality. So we only use these if they failed everything else. Increased mortalities with these, particularly if they have a history of an MI. Remember the name of that landmark trial that I told you? CAST, the CAST trial, showed us that if you have had an MI and you take one of these drugs, you are at a 2 to 3-fold risk of more of dying. So we would never, ever use 1C agents in someone who has had a heart attack. This is specific to 1C agents. And know, too, that this one does aggravate heart failure. So I'm going to put a contraindication. I don't know why it's not listed here, but add a contraindication for heart failure. Because, again, this can cause heart failure. So we'll be very careful with anyone who's had an MI or anyone who's had heart failure. Daniel, did you have a question? So it can be ventricular, like if it's a sustained ventricular tachycardia, that's the first one. But we're thinking of it more for atrial if they failed other measures. So, class 1A, we had our double quarter pounder, lettuce and mayo, not requiring that you know pickles. And remember, these were the ones for ventricular arrhythmias. So, you know how there's some people with their burgers, like they're really particular on like if the cheese and the bun and where the lettuce goes? My husband is, like, he wants it in a certain order. Well, the lettuce and mayo, those were ventricular only, so just think lettuce and mayo go on the bottom, okay? They're mostly going to be in ventricular arrhythmias. And then last up, you've got fries, please. But which patients do we not want to use 1C agents in? Heart failure or MI? Well, if you've had an MI, they don't need fries anyway, right? So that's a way that you can remember not to have the fried fries. Does that make sense? Little easy way to remember it. Okay. So before we go into the next section, focus on these last two drugs. This consultant RX, he does a lot. He'll ask you to figure out the drug with the emojis. So before we go into class 2, wink wink, which is beta blockers, what drugs are we describing with the carvedilol and not metoprolol. Labetalol. So la for music, making a bet on the horses. A law. There you go. There you go. All right. So that was fun, right? Fun beta blockers. Okay. We're going to try something. This is called a back channel. If you have a QR scanner, you can scan it here, or you can go to this website. So it's answergarden.ch /103-5375. answergarden.ch /103-5375. You can do that on your phone, on your tablet, computer, wherever you are. And there should be a question waiting there for you. Is it asking you for a password to get in? No. Okay, cool. So tell me what you know about beta blockers already. And I went ahead and added, it ends in LOL. So we should be able to see how these come in. The bigger they are, the more people who have said them. So decreased heart rate, absolutely. That's like what everyone knows. I see INO and chrono. Somebody define those terms for me.
Less strength of contraction and timing of contraction.
Okay, which is which? She said decrease strength of contraction, decrease rate of contraction, but which is which? INO is strength. Chrono, I think clock, time, that's decrease in rate. Good. I see some of you are giving me drug names. Let's update and see what's coming in. Can worsen asthma. That's a good one. Banned from the Olympics. Yep, we talked about that one. Horse meat? I have no clue what that means. Is there some... Y'all learned about horse meat? I don't know. You'll have to catch me up about that one during the break. Good. So you know quite a bit. Not first line in hypertension, but if a patient has had a heart attack, we know that it's actually really good for those patients. Cool. Okay, so you know quite a bit already about beta blockers. That's why we're not going to spend any time on them here. We've already gone over the mechanism quite in depth, but it is working at the SA node and the AV node. It's really, really strong at the AV node, though. So here, it's more sensitive. The AV node is more sensitive to blockade than the SA node is. So this is why we use it when we have any type of atrial or supraventricular arrhythmia, because we're going to try to get that arrhythmia to stay in the atria and not move down to the ventricles. So this is probably our most useful antiarrhythmic because it is used in supraventricular, ventricular, and especially if they've had a heart attack. So we've got wide clinical application here. Plus, it's a pretty good safety profile, right? Compared to the drugs we just talked about, wouldn't you much rather take a beta blocker? So I've summarized some of the side effects here. You've already mentioned them to me, but let's just review. Why bronchospasm? If it is a non-selective beta blocker, it's also going to hit beta 2 receptors, which are in the lungs. Good. Cold extremities? Somebody work out that mechanism for me. Somebody be brave and push your mic and say it.
Is it
Jordan's on the right track. Give it to us, Jordan.
It's vasoconstriction in the periphery.
Right, vasoconstriction in the periphery. Normally, let's go normally, alpha receptors constrict and beta 2 that are in the periphery dilate. So if we're blocking dilation, then we have a relative constriction. So that means we're not getting that warm blood out into the periphery, which makes your extremities cold because you've got less blood flow there. Impotence. Same, right? So we can't have dilation to increase blood flow to the penis to cause an erection.
Dr. Castleberry?
Yeah.
Could it be that the bradycardia could cause the cold extremities too? Like you're just...
Could the bradycardia cause cold extremities too? Maybe. It's still blood, not warm blood getting out to the extremities well, but I think it's probably more of the beta 2 not being able to dilate more than anything. So those are smooth muscle spasm issues. We've also can have an exaggeration of the good effects, right? You've already told me negative chronotropic, which is that force of contraction. When would we not want that? When would this be really bad? So we can't squeeze very well. What disease state already has a mechanical pumping issue? Heart failure. Now, this is paradoxical because you're going to learn here in a few weeks that we actually give beta blockers to people with heart failure. But you're going to learn how to give it just right. Could cause a heart block. We talked about that on Monday at the AV node. And, of course, bradycardia makes sense. And then the ones that are lipophilic and can get into the brain by crossing the blood-brain barrier, those will cause some insomnia or depression. Yeah?
What was the reason for the impotence again?
So the reason for the impotence is that, same with the beta 2 being in the vasculature, normally beta would cause dilation, but if we're giving a beta blocker, we have more of a vasoconstriction in those blood vessels, so we don't have blood flow to get to the penis to have an erection. So the agents that I want to point out here is that it's not the ones with ISA. Do you remember what that means? Intrinsic sympathomimetic activity. Way to go, Wyatt. Intrinsic sympathomimetic activity. So it's mimicking the adrenergic nervous system or your sympathetic fight or flight type nervous system. We don't want those drugs because we're trying to decrease the effects of that sympathetic tone, right? To control the rate. So we wouldn't use any of those agents. You're most likely going to see metoprolol. That's why it's bolded here for you. Or esmolol. So this is used a lot IV in the intraoperative period because its half-life is so short, so you can give it really quickly. But it's the only available in an IV formulation. So again, I'm not spending a lot of time on beta blockers. You've already had them in hypertension. You're about to have them in heart failure. You're going to have them in myocardial ischemia. Probably going to touch on them in headaches. You're going to see beta blockers everywhere, right? So we're not going to spend a ton of time here. You need to understand the mechanism, which is what we talked about on Monday. So I put this in just because I thought it was a good resource for you to see later. It is dosing equivalents of beta blockers, so I think that would come in handy when you're on fourth-year rotations. And then the last one, this is to reiterate what we had talked about on Monday as far as where beta 1 and beta 2 are located, but I learned something when I was looking at this. Do you always forget which ones have alpha, mixed alpha and beta? carvedilol and labetalol, they don't end in just OLOL. So they have an I and an A before it. None of the other ones do. I've never noticed that before. So anyway, I learned something on this. All right, it is 10:50 straight up. So let's go ahead and take our, well, I guess not straight up. Almost. So we'll go ahead and take our 10-minute break, and we'll come back with our potassium channel blockers.
So I've seen a lot of patients on flecainide for a long time. Is that typical?
So what my guess would be is that, first of all, they have no cardiac issues, right? They haven't had a heart attack.
And I'm just like, should I say something?
Yeah, that's like a black box warning.
They also said they tried to prescribe him another antiarrhythmic. I don't remember. I think it was amiodarone or something like that. That was like
That's a class 3 agent,
Yeah,
which is kind of taken over from one.
right, like at the same, but they didn't discontinue the flecainide, and that's why I'm like, I don't know if I'd like this cardiologist. We didn't fill it because we were just like, no.
Yeah, that's,
But
I would be very scared to do that when you look at the Castrol data. Which Dr. Lamb, he'll show you the Castrol, but that would scare me too. So he's still on the amiodarone.
still in the flecainide, but we didn't do the amiodarone.
You didn't fill any amiodarone.
Yeah.
But you gave him the
Well, we called and we were just like, can you please tell us which one to do? And they were just like,
both.
yeah, they were just like, both. And I was like, well, if we're not discontinuing the flecainide, we're not filling the amiodarone.
Oh gosh, well that's. I would have done the amiodarone.
Yeah.
Honestly, between the two.
So that's the other thing is like if he's been on the flecainide, now knowing that he shouldn't be on it with the heart attack, like maybe if he had the heart attack and that's why they were trying to switch him to the amiodarone, that would make sense to me. But I don't know whether it's just like, how sometimes nurses are not really sure what the
They just know we want them on both.
Yeah.
Whatever. Yeah. It's definitely concerning because it is a black box warning for side-effects like that. So because the Castrol just increases the value. So that is about that.
I know that like the nurse was saying his arrhythmias are like to the point where they're worried that he won't be able to like ever go on. Like they're trying to do as much to it as they can, but it's like, okay, well, did we kill?
They're 2 to 3 times more.
Yeah.
But I mean,
It could just be like a, hey, we want to
he's
give him a
tried
couple more
everything
months to a
else.
year,
That might be that they don't really care about the long-term mortality.
just like comfort.
To keep them. So this is inpatient or outpatient?
Outpatient. I work at HEB.
Okay.
But, yeah, I when I saw the flecainide was, one of those ones that you shouldn't use with failure, I was like, I remember that patient. I remember all the conversation we had about that.
Yeah, they're scary drugs. They really.
Yeah, I've seen most of the patients that have died since I've been working there have been on these meds. I'm just like, oh, now I don't like them.
They're to be respected for sure, and that's why not everyone can dispense them. So I can't remember. It's a REAPS program, right? So y'all must have the
Yeah, we monitor
authorization
it,
to be
but
able to
we,
do
yeah,
it.
we,
And only certain cardiologists can write for it.
Yeah.
Or it had been started in the hospital first. So.
yeah, we sort of treat those like the same way that we do like Suboxone and stuff, where it's like we check their DEA
Mm-hmm.
if they've never written for one before.
Mm-hmm. Man, yeah, it's
And it's great when the supervising physician doesn't sign the paper or anything, and it's like the resident or someone that writes for it. And it's
like
like,
you're really like
no.
Yeah, they definitely want to call him. But in that situation, I would be really nervous. But you're right, maybe they're giving him. And they're not concerned about 5-year mortality.
Yeah,
because he's
that
got
could be
6
true.
months.
Yeah. I haven't really asked about that sort of thing. 'Cause
Well,
how do
that's
you?
exactly. That's when you really need to talk.
Because it's not like, hey, patient's wife. I know patient is bedridden, but like,
Exactly. Yeah, exactly.
how much time did the doctor tell you you had, if any?
Exactly.
Which that's
Yeah. But you did your due diligence to call.
didn't get a great answer. That's what I
Yeah.
called.
Yeah, that's a really good story.
All right, so now I can say it is straight up 11. So we'll come back and finish out. So we've talked about the class 1 agents, which were sodium channel blockers. Those were divided into subclasses 1A, 1B, and 1C, which all have something different, but you know how to categorize those drugs. Just remember there's 2 P's, pounder and please. So don't get your P's mixed up there. If you only memorize the acronym, know which P is P. And then we did beta blockers, but very, very quickly because you already know a lot about beta blockers and we'll learn even more about them. But if I have an arrhythmia, I probably want it to be one that'll be treated by a class 2 agent or treated by a beta blocker. So class 3 are potassium channel blockers. We'll do class 4, which are calcium channel blockers. Then the miscellaneous ones that really don't fit anywhere very well. But class 3 agents have really replaced class 1 agents. We'll still use class 1 when we need to, but for the most part, you're going to see more of class 3 being used. So mechanism we've already gone over, but just to reiterate, it will lengthen that plateau phase or that effective refractory period. Here's why that is so good. When we had the arrhythmias, let's just use atrial fibrillation, for instance. So I'll come back over here to our little click. If you guys have the arrhythmia and it starts in the circuit and it is spinning round and around, if for one of you, let's just say, Jose? Josh,
Close
sorry.
enough.
Perez. Gotcha. Josh. If Josh, for instance, if we have increased that effective refractory period, we've blocked potassium, so his inactivated period of the action potential, it's going to interrupt that circuit, right? Because even though everyone else is saying, hey, Josh, we need another action potential. Come on, Josh, play with us in this circuit. And he's like, it's taking me a little bit longer to get through this action potential. And he can't be excited again, right? So then that circuit starts to die down when a part of the heart has that longer effective refractory period and can't be stimulated again. Does that make sense? So that's why these drugs work, to increase that effective refractory period, and it's really good at decreasing the incidence of that reentry or that circuit that gets stuck. Reverse use dependency. That's something to know here on these agents. This is not a good thing, okay? This is saying the action is most pronounced at slower rates. So that means we have more of effect when the heart rate is slow. Okay, so if the heart rate is slow already and we just increased the plateau phase or we've increased that ventricular action potential, we're really putting a patient at risk of torsades here, right? So that is not a good thing. And it's actually not working, or it's less pronounced at the fast rate. Well, that's where we want it to work, right? When you have the atrial fibrillation and you've got a fast beat, we want it to work there. So we still use these drugs, they still work, but this is not a good, reverse use dependency here is not a good thing for potassium channel blockers. But amiodarone is an exception to that rule, so that's why out of all of these drugs, you probably are going to recognize amiodarone the most. No effect on upstroke or conduction velocity. Why is that? Okay, so in the SA node, those would be funny currents that are carried by sodium. In ventricular myocytes, the upstroke is carried by sodium. Phase 0 upstroke is carried by sodium in ventricular myocytes. We're not affecting that. We're just affecting potassium here. So that's why there's no effect. So we're going to talk about 5 drugs in this class. Ibutylide is kind of our prototype. I guess it was the first. It is available IV. Dofetilide is PO. You don't have to know brand names, but if you've seen Ticcasin, that's what dofetilide is, Ticcasin. It has its own REMS protocol that Only certain pharmacies can dispense it. Only certain physicians can write for it. So it is very much protected. So we'll usually start them on maybe Ibutilide in the hospital and switch them over to Dofetilide PO when they leave. And then I already warned you that Sotalol shows up here. If I ask you on the exam, which class does Sotalol fit into? What is the answer? 3, not 2. Not 2. Even though it's a beta blocker, it has more properties of a potassium channel blocker. So we call it a class 3 agent. So again, we are looking to convert an arrhythmia here. We're usually giving these in the hospital. If we have to send them home to maintain, we will, but we're trying to get rid of the arrhythmia. We're not just doing rate control like we were with beta blockers or with calcium channel blockers. We're trying to actually do a conversion, but we use these a lot in AFib. So again, conversion here. Dofetilide, since it is PO, could be used for maintenance, but hopefully we could use a different drug to keep them in maintenance versus this one. So the really important thing to note here is that both of these are going to, let's do Ibutilide and Dofetilide first since they're similar. Both of these are going to be started in the hospital, and you are going to be on an EKG monitoring for QT prolongation. Ibutilide at least 4 hours, but Dofetilide is more like 3 days. So you are literally in the hospital, hooked up to telemetry, all to watch for QT prolongation because the risk of torsades is so high here. So if you already have some sort of pre-existing prolonged QT, or you would not use one of these drugs because we know it's just going to make it worse. Or if there are other drugs that the patient's already taking that we know will add to prolonging the QT interval, we are not going to use these in combination. So maybe we stop the other drug, maybe switch them to a different type of antihistamine or a different type of antidepressant if we really have to use this drug. But the risk is additive when you use multiple drugs that increase the QT interval. Note, Dofetilide, we've got to be really careful with renal function. And again, because the risk of inducing a ventricular arrhythmia like torsades is so high, we are really just reserving it for patients who are highly symptomatic with AFib or aflutter. We're going to try to use a different drug if we can. It makes sense that bradycardia would be an adverse effect, right? If we are prolonging the action potential, then there's less action potentials that would happen. See if there's anything else I want to show you here. I think that's it on those two. So Sotalol. Sotalol is actually a stereoisomer. So those isomers have different effects. In fact, one has the class 3 effect that we put them in, and both of the isomers actually have beta blocking potential. So that's why we're seeing them really in both classes. We're putting them in class 3, but it gets down to the stereoisomers as far as which has which activity. I'm not going to make you memorize which is which, but that's how it's the isomers that have different effects. So you should recognize all of the adverse effects because they're going to be similar to all of the ones that we've seen before. It actually is pretty well tolerated. There's your fatigue, dyspnea, bradycardia. Still a risk of torsades because this does have potassium blocking properties. But we would be very careful in asthma patients, because this is a non-selective beta blocker. So we will block some beta 2 receptors in the lungs as well. We would be very, very careful in heart failure as well. because again, it's the negative inotropic effects of beta blockers that could exacerbate a heart failure attack. But we use this usually in patients who can't tolerate amiodarone. Amiodarone's really more of our go-to here if we can get away with it. But it says use in caution with patients with impaired renal dysfunction or impaired renal function or diabetes. Why diabetes? Okay, so beta blockers do change glucose metabolism, but then they also cover up the signs and symptoms of hypoglycemia, right? Like the tremor, the heart rate. There's only one symptom that doesn't go away when it comes to hypoglycemia in a patient being on a beta blocker. They will still get one hypoglycemia symptom. What is it? No, because beta blockers are used to treat headaches. Fainting? No, it's not fainting. Hopefully we're preventing it before fainting. Sweating. So you would tell a patient that's on a beta blocker, if for some reason we need them on a beta blocker and they do have diabetes, we'll be monitoring it, but we would tell them, if all of a sudden you just start sweating, like for no good reason, you're watching TV at night in a air-conditioned home and you just start sweating for no reason, check your blood glucose because it's likely that the beta blocker has covered up all of the other symptoms of the hypoglycemia. Okay, so now amiodarone, which is really the one that I think of, it's the workhorse for the class 3 agents. You got to know amiodarone. Dronedarone is, quote, the new amiodarone that's supposed to have less side effects, but you'll see some trials that say, yeah, it's true, it has less side effects, but it's not really as effective as amiodarone, so I still see a lot of people on amiodarone. But these are the side effects, and pretty much all of these you need to know for amiodarone. But the big ones, and the way that I remember it, is with an abbreviation TELLS, T-E-L-L-S, which stands for thyroid. It can cause hypo and hyperthyroidism. And I'll show you why in just a minute. It'll cause corneal microdeposits, so they can go blind in the eyes, thyroid, eyes, liver. There's definitely hepatic toxicity, so we are monitoring LFTs. Remember what your LFTs are? AST, ALT, or what's the better indicator? Albumin or platelets, because those are created there. So thyroid, eyes, liver, lungs. It will actually cause pneumonitis and fibrosis. Particularly the fibrosis is what we're so worried about. And so we do pulmonary function tests on a regular basis for patients who are on amiodarone long term. And then the last one is skin. What do you know about amiodarone and skin? This is so weird. It, to my knowledge, is the only drug that does this. Photosensitivity, but lots of drugs do photosensitivity. What happens when they are exposed to the sun? They turn blue. Yes, and I'm going to show you a picture here in just a minute. I don't want to get off this page or it'll take off all my notes, but the patient's skin can turn blue. I'll show you what it looks like and give you some examples. But you have to be monitoring this drug, and you'll probably learn the specifics of what's every 6 months, every 3 months, what you have to monitor. But if you see a patient on amiodarone, you need to be asking, have they had these tests recently? And also talking to them about how to protect their skin and wear sunscreen or long sleeve clothing when they're out in the sun so that they don't turn blue. Because the problem is amiodarone has a huge half-life, like a week's. So even when you stop the drug, if you start to see, oh wow, their nose is turning a little bit blue, let's stop that drug. Amiodarone can be detectable in their system for a year. So the blue coloring is not reversible because by the time you realize it and stop the drug, they're basically still have it in their body for a whole year. So a ton of drug interactions here. Amiodarone needs to be a legit red flag drug for you. When drug interactions come up, this is one to pay attention to. Like I mentioned, dronedarone, it's kind of the newer amiodarone. It's supposed to have less of those effects, but it's not quite as effective. Something to know here is to take it with food. That'll help decrease some of the side effects. But it has a shorter half-life. So it is a twice-a-day drug. So it has a 24-hour half-life, but we still give it BID. So if we are having adverse effects, we can stop it and it be better than amiodarone. Now, what you need to know about these two drugs, it's very important, is that it fits into, both of these fit into every single von Willems class. They block sodium channels. They have beta blocking properties. You already know they have potassium blocking properties because that's where they live. That's where we put them. But then they can also block calcium channels. So amiodarone and dronedarone have, technically could be in any class. We put them in class 3 because that's predominantly where they have their effect. Yeah, Audrey.
Is amiodarone, even though it has all these really weird bad side effects, is the reason we like it so much because it doesn't prolong the QT intervals? So is that what we're trying to avoid?
So we like it. It is effective. We monitor for the side effects, except for the blue skin. We can deal with most things here, but it is very effective. To me, it's kind of like warfarin. It's one of those that's scary. Like if you look at it all, you're like, oh my goodness, I would never want to be on that drug. But it's tried and true. It works. We know how to dose it. We know how to handle it. Like it's predictable, and so we like it. So here's what I was telling you. It has mechanisms in all 4 of the classes. So like for blocking sodium, it doesn't really do that initially because we give a loading dose IV. And then, of course, they would be on it PO. So it doesn't really do anything for sodium initially, but long term we do get a blockade. And really that's what we're looking at most. When the sodium, it would be a long-term effect. For beta blocking effects, it's pretty much the same throughout. The potassium channel blockade is we don't see that initially, but long-term, that's where we put it in that class because that's really where the effect is coming from long-term. And then calcium, it's pretty much the same all the way through. So your beta blockade and your calcium channel blockade is pretty consistent, but your sodium and potassium blockade increases the longer you're on the medication. So on the exam, when I say, what class is amiodarone considered when it comes to von Willems, what's the answer? 3. The answer's 3, but it has properties of all 4. So here's the issue with amiodarone, especially with thyroid. We know that thyroid loves iodine, right? So amiodarone has iodine in it, but you don't see that with dronedarone. So we don't really have thyroid effects with dronedarone. So I told you Physician Doodles likes to think of ways for you to remember the side effects. So these are the ones for amiodarone. You'll see that TELS is there, plus a few extra ones. But you need to know how to monitor amiodarone. I promise you will see a question about amiodarone adverse effects on the exam in some way. Because honestly, physicians do forget to continue that monitoring. They'll do all the baseline things, like before you can give it, you have to run all the baseline tests, but then they forget to check in on that monitoring. So keep an eye out on it. This is some example of that blue skin. You can see it mostly on the nose, but it's wherever sun would be exposed most often. Here, again, you can kind of see it on his nose. It's starting to come up a little bit on his neck. Now, this is rare. It is extremely rare, but it's one to watch out for. It's one to counsel on. So I have seen 2 patients in my career that have had amiodarone-induced blue skin or that toxicity. And it's kind of sad because when they come on the floor, everyone's like, oh, amiodarone-induced skin toxicity, room number so-and-so, because you don't see it. And so when it happens, you actually want to see it because you learned about it in school and you want to see what it looks like. So it's funny if you watch the rooms, people walk by real slowly, like on the windows, just to try to catch a glimpse of what it looks like. It's usually pretty subtle. Again, it depends if it can be caught quickly and drugs stopped, then maybe it won't continue to get worse. But it's usually like on the nose, around the neck, or on the arms is where you see it.
Does wearing like a lot of sunscreen help with this?
Yeah, absolutely. So you just need to protect them from the sun. So wearing sunscreen helps, but they need to know that. Who's going to tell them that, pharmacist? That's your job.
Do we get any presentation with like the eyes as well? Or?
So I don't think it actually changes the pigmentation of the eyes, but it does have little micro deposits that get in the cornea, which can cause long-term damage to the eyes. But I don't think it changes the color of the eyes. That is a good question. Y'all look that up and tell me what type of sunscreen is the best. I'm not sure if there's a certain type. To me, I'm telling them to wear long sleeve clothing and a hat to try to protect, actually have a real barrier. Okay, so I told you that for real, this is a red flag drug that you need to note. I'm going to have you do this on your own. In fact, let's mark off simvastatin and lovastatin. I really want you to focus more on warfarin and digoxin. I want you to look up and tell me the category of interaction that occurs. We're not going to do this here. This is for you to do as homework as you're studying for the exam, but I think it'll stick better when you look it up yourself. Warfarin and digoxin, tell me what category is the interaction, but then what do we do about it? Because let's think through this. If a patient has AFib, we have them on amiodarone. Well, we already talked about how patients are at risk for a stroke because of AFib. We talked about that mechanism in detail. Therefore, they're probably going to be on anticoagulation, depending on what their CHADS-2 VAS score is. You're going to learn that with Dr. Lamb, don't worry. But according to their score, they will get a certain drug. It might be warfarin. It could be a DOAC, but it could be warfarin. So they very well could be on both of these drugs at the same time. What do you do to mitigate the interaction? And then digoxin is another antiarrhythmic agent that we'll talk about here in just a minute. It's possible that they would be on both. So these are real potential interactions. I'm not just picking random ones. These are ones that you're likely to see, and you need to know what to do with them. Here is amiodarone. He really talks about the side effects here, so you can go back and kind of read through it if it helps you. I'm not going to pull like one single detail from this post and test you on it, but I think sometimes when you see it in real life, it's just helpful and it sticks better. So he talks about monitoring PFTs, which are pulmonary function tests. My pen just stopped working. Try again. Well, little technical difficulties. I will show you here. PFTs for pulmonary thyroid function test because it can cause hypo and hyperthyroidism because of that iodine, and then LFTs, so liver. I guess you could also think, just liver for that one. So feel free to look through that, but I'm not going to pick out some little tiny detail for you. Okay. Calcium channel blockers. So class 4, and I told you it is only 2 specific calcium channel blockers. It is not the entire class. So your dihydropyridines are all the ones that end in penes. Throw some at me. Nifedipine, amlodipine, felodipine. Those are the common ones. So those we're not talking about. We're talking about verapamil and diltiazem here because those are the ones that work on the heart. Now, it will lower heart rate, so that's a good thing in arrhythmias. But, of course, the adverse effect here would be bradycardia. So let's see if there's anything here that I really want to point out. The toxic effect here would be, sorry, I've lost my pen. Let's see if I can hop out and come back in. Make it better. Yeah.
If you plug it in, it'll reconnect.
Oh, actually plug it? Okay, let me see. Let me try one more thing. Because if I plug it back in, it's going to disconnect from here. But it's looked like it's not picking it up at all. So let's try it. You got to love the Apple Pens, right? I think they're awesome. I see a lot of them in the room. Raise your hand if you have an Apple Pen. Look at that. Oh, my. That's awesome. Well, unfortunately, still not recognizing it. So that's okay. We'll roll with the punches. It was fully charged, so I don't think it's dead, but we'll run with it. Okay, so something to note here. We'll go old school Vanna White. Toxic effects would be an AV nodal block. So we said that this is like the bouncer at the AV node to only let certain signals go through. And so it could be that those bouncers get overzealous and don't let any signals through and actually have an AV block where we would need to defibrillate the patient. If they don't bounce back from it, then they would have to have long-term pacing, like we'd have to put in like a pacemaker to overcome this. So negative inotropic effects, so we do not use these drugs in heart failure patients at all. So again, we're not spending much time on calcium channel blockers. Know the mechanism, and you should know it's verapamil and diltiazem and those adverse effects. But you're going to learn calcium channel blockers in a ton of other sections as well. You've already learned them in hypertension. They're going to come back in other sections. So I don't want to focus here because you're going to be tested on those in other places. Now, we do have some miscellaneous agents that we need to get through. I say class 5. This is like unofficial, but basically they're just everything else that don't seem to fit in one of the others. So we've got first adenosine. You should know that adenosine is the first line agent for narrow complex paroxysmal supraventricular tachycardia, PSVTs. 90% effective. Those are pretty good odds, right? So this is usually like teenagers that come in and have this palpitation, maybe when they're doing some sort of exercise, and they come in, give them a little bit of adenosine or a calcium channel blocker. But if we can do adenosine, it's going to be 90% effective to get rid of those PSVTs. Now, it's an extremely short half-life, 10 to 15 seconds, because adenosine deaminase catches it quickly and metabolizes it. So we give it as an IV bolus. So the adverse effects here, even though they're a little bit scary, right? Chest pain and tightness, headache, bronchoconstriction, another arrhythmia, dizziness, doesn't matter. Such a short half-life, they're probably going to be okay in a minute or so. They just have to get through it. Now, a lot of patients, though, will have this feeling of, quote, impending doom with adenosine. And it's probably all these things. I mean, your chest gets tight, you're out of breath, you're in an ER anyway. So anyway, adenosine kind of has this bad rap, I guess, for this impending doom that patients feel. But get through it. It'll be okay in a minute or two. Here's a little bit about adenosine to look at and how they use it. I think he talks about the impending doom in here as well. He also talks about caffeine in this one. Remember the link between adenosine and caffeine? Right? So look right here. I think you'll see that that's interesting. Caffeine is adenosine receptor antagonist. So might be something to think through as you're drinking your coffee. Okay, DIG. We've got to stop and talk about DIG. If you think that it's not important just because it's a miscellaneous agent, you are mistaken. This is a very, very commonly used antiarrhythmic agent that you need to know very well. It has some crazy side effects with it too that require a lot of monitoring that you need to know what the symptoms are. I'll give you a personal story how I caught a digoxin toxicity. So let's look at the actual mechanism by looking at a figure. Let's see if I have it next. Yes. I love this figure on digoxin. So here's how digoxin works. And this little stepwise process works you through it very well, but I'll show you here what happens. So digoxin binds to this sodium-potassium exchanger and just stops it from working. Okay? So if this is no longer working, where does sodium build up? This is inside the cell. So inside the cell, outside would be up. So we've got a lot of sodium because it can't get out, right? Like digoxin has just blocked the door. So we have a lot of sodium here. Well, now let's go down here. Normally, this exchanger would take calcium out and bring sodium in. But if we've just increased the concentration of sodium here, is this exchanger going to work? No, why would it pump more sodium into the cell? It's not going to. So now, if it's not pumping sodium in, that means it's not pumping calcium out. So now we have an increase of free calcium. What's that going to do to a muscle contraction if we have more calcium available? Strengthen that force of contraction. What's the medical terminology for that if we increase force of contraction? Positive inotropic effects. So digoxin has positive inotropic effects. But it has negative chronotropic effects. It decreases heart rate. If we go back to the slide before, it has prominent vagotonic action. Your third bullet point here. Vagotonic action. And it gives you a little bit of reasoning why. But basically it's going to increase the action of the vagus nerve, which we know slows down heart rate. So we've got a good increase in force, but we've got a decrease in the heart rate. And just like beta blockers and calcium channel blockers, it has prominent effects at the AV node, which is a good thing because we can stop those atrial arrhythmias from turning into ventricular arrhythmias. So that's why it's really good with any type of reentry that involves the AV node because it's able to be there at the AV node. So anything where we had a reentrant tachycardia that could help with. But if we're trying to use it to decrease rate in AFib, it won't work on a patient that's had a heart transplant. And that's because in heart transplants, the vagus nerve has been cut or denervated is the word. There's no vagus stimulation to that new transplanted heart. And so you won't actually see the decrease in heart rate in patients who have had a transplant. Just fun little fact. Does this mechanism make sense on digoxin? You have to understand how that works. Now tell me, I'm going to skip. Hold on, I'll come back to it. Getting ahead of myself. So adverse effects, extremely common, okay? Digoxin toxicity happens a lot, and it can cause those DADs, the delayed after depolarizations. Why is that? Calcium, right? Remember DADs? It happened with an overload of calcium. Well, what did we just do with DIG? We increased calcium. And so we can cause the delayed after depolarizations. Now, we do have an antidote. So when we see digoxin toxicity is real, we have something called Digibind. Don't you love that? Tells you exactly what it does. It's actually from sheep, but it's an immune fob that actually goes in and binds to digoxin. And so removes it from the circulation. If we need to use it, we can. Digibind. So some kinetics here. Definitely know the intestinal microflora can metabolize digoxin. So if you have a patient who goes on an antibiotic, all of a sudden, you've just destroyed your gut bacteria. What just happened to your blood levels of DIG? It went up, right? Because that bacteria is not there to chew it up. So you could see digoxin toxicity in that type of situation, which you would know. They're coming into you to get their antibiotic, right? Let's see, renal elimination. We have to be really, really careful if there's any change in renal function. This is where I've caught DIG toxicity before. We had a patient come in, and not gonna lie, she was a little bit of a hypochondriac. She came in all the time. This was an ambulatory care clinic. And so it's wrong, but there is a sense when you see the person who's there all the time that you're just kind of like, oh, she's here again. It's probably just a stomach virus. No big deal. Well, she starts complaining of kind of some weird symptoms. There's some flu-like symptoms, some dizziness, a lot of nausea, but visual disturbances. She was saying that things looked yellowish to her. That should be a red flag for you for digoxin. It has visual disturbances. It's going to be on the table for you. But visual disturbances that people will also usually describe it as a halo around things. Like if you were looking at someone's face, their head's kind of glowing a yellow or a greenish color. Those visual disturbances, that's not normal. That doesn't come with the stomach virus, right? And so I started looking back. I'm like, hold on, that is a red flag to me. Why is she saying that? Started looking back, and a month ago, we had started her on an ACE inhibitor. Well, you guys already know that ACE inhibitors can cause an acute kidney injury. And so we're like, you know what? This is worth checking in. We sent her to the ER. Her creatinine was really high. We checked digoxin levels sky high. I mean, she was toxic with digoxin. But it was one of those situations that you're like, the flu-like symptoms, the nausea, those are just so ubiquitous, right? And she comes in all the time. But we happened to be paying attention and actually followed up on it, and that was her issue. So you've got to be careful with any drug. If you add any drug, they're already taking digoxin, and you add something that could throw off their renal function, you need to tell them the symptoms to be looking for, because they might not come in either, right? They might just say, oh, it's just a stomach virus. It's flu season. I probably got the flu. They need to know. Okay, hypokalemia, low potassium will increase digoxin-induced arrhythmias because all antiarrhythmic agents are arrhythmogenic. Why would low potassium? Let's go back to the mechanism. Potassium's at play here. That's the same site that digoxin binds to. So if digoxin and potassium are both interacting at the same place, if digoxin is there, it can compete with potassium. So if there's low potassium already in the body, who wins that fight? If it's dig and potassium fighting, and potassium's already kind of weak, dig wins. And so you will see more adverse effects in that situation. So we actually keep patients' potassium a little bit on the higher level. So they will be more towards the 5.5, and we're okay with that because we want there to be some good competition there with the dig and potassium. So look through digoxin here. Again, you need to know everything when it comes to those adverse effects. The common ones that are here would be that muscle weakness, blurry vision, yellow-green halo, nausea, vomiting, that's leading to anorexia. Those are the things that you need to counsel a patient on. And for the therapeutic considerations, you've got to be really careful with drug interactions. So amiodarone is a red flag for drug interactions. So is dig, okay? Especially when combined with other drugs that work at the AV node. What other classes of drugs have we already talked about that are at the AV node? Calcium channel blockers and beta blockers. We will use them in combination with dig, but we would be extremely careful because we don't want to have an AV nodal block. So same thing here. You would have already looked up the amiodarone interaction, but look at verapamil too, because it is possible that we would be using those in combination. You can mark off spironolactone and quinidine for this, but let's just look at amiodarone and verapamil, because if we use those in combination, what would be your recommendation to make sure that we can mitigate that interaction? All right, potassium. Potassium actually can be an antiarrhythmic agent because high potassium and low potassium will both cause arrhythmias. So treating it either way could potentially get rid of the arrhythmia. you can see why that is. Hyperkalemia will cause it because it slows the conduction velocity. So that could interact and cause a arrhythmia. Or if the potassium is low, you have the risk of after depolarizations, both early and delayed. So just know potassium is a strategy for high or if it's high or low. Magnesium, so another electrolyte. We don't know exactly how it works, which you love that, right? You're like, oh, don't have to memorize that mechanism because we don't know how it works. But we think it's something with sodium, potassium, ATPase, and how it works. But you definitely should know this is how we treat torsades, okay? We've talked about torsades, life-threatening, got to treat it fast. You treat it with magnesium. Even if their magnesium level's fine, this is still the treatment for torsades. It's also the treatment for digitalis or the digoxin-induced arrhythmias if they have low magnesium. It could be that it helps with digoxin, but we're going to try Digibine first. But if you see that they also have low magnesium, it's worth giving some magnesium as well for digoxin.
Would that be just with IV Magsulfate?
Yep, so we just give it IV. Yep. In fact, the next picture, mag sulfate. This is a little bit, again, you can read on it, but just how they're using it. He actually gives a mechanism as a potential real mechanism of action. I haven't looked at it in depth because everything I've seen is like, we're not exactly sure how it works. But look through there and you can see how he uses magnesium. All right. That's all the drugs. And again, yeah, it's kind of a lot of drugs, but really it was the 4 main classes plus a few miscellaneous ones that you have to know. So it's good because there's only a few mechanisms for you to know. Now, I like this table. This is here more for FYI, just as a summary, because I think it could be a good resource for you later. If you're saying, oh, this patient has heart failure, why or which antiarrhythmic should I not use? And it's listed there. So either don't use it or be extremely careful with it. And they should make sense. We've talked about a lot of them as we went through. So we talked about heart failure. We talked about history of an MI, how we wouldn't want to use which class, flecainide, for after an MI? 1C, right? The fries, please. Flecainide there. Prolonged QT. Those are all the ones that are going to prolong QT. So it'd be, if they already have a prolonged QT, we wouldn't want to add something else. And then the cardiac transplant adenosine wouldn't work. Let's see. And then non-cardiac, those are mostly just adverse effects. You know, diarrhea was really bad with quinidine, so, you know, maybe we don't use it. But risk of diarrhea or treating an arrhythmia, probably going to treat the arrhythmia and they can deal with the diarrhea, right? So some of these adverse effects we might still do, but lung disease, for instance, we would not use amiodarone because of that risk of pulmonary fibrosis. So look at this one kind of in summary. Once you've learned the drugs, and I think you'll go back through and say, oh yeah, that totally makes sense. I see why that is. So I think this is my last slide. This is perfect timing. Give you time to do the evaluation. I mentioned this to you on Monday. We don't treat all arrhythmias. And you will actually have Dr. Lamb come in. I think he's next Monday. And he will tell you specifically, these are the ones we usually use in practice. These are first line. But if the arrhythmia is not hurting them, then maybe we just let them have it. Or if the arrhythmia could be dealt with non-pharmacologically. Like if we can do the direct current cardioversion and get their heart back on the normal pace, we'll do that because then you don't have to be on these drugs long term, which carry side effects with it. But I want to reiterate, there's really 2 types of treatment approaches when it comes to atrial fibrillation. That is by far the most common type of arrhythmia that you're going to see. There's 2 approaches to it. Rate control would be, let's beef up that AV node so that the reentrant tachycardias that are happening in the atria don't make their way down to the ventricles. So digoxin, calcium channel blockers, and beta blockers are the ones that we use there. If we are going to try to do a rhythm therapy, so we're trying to convert them or keep them in a normal sinus rhythm, then quinidine, flecainide, unless they've had heart attack, and amiodarone are usually the go-to ones there. But you've got all the contraindications, so there's instances where you will use different drugs, but these are some of the ones that I think of first. Again, asymptomatic patients don't have to have therapy if they're okay with living with the arrhythmia, but for AFib, they will most likely be on anticoagulation to prevent stroke. And remember my pet peeve, they are not on an anticoagulant to treat their arrhythmia. They are on an anticoagulant to prevent a stroke that could result from the arrhythmia. So, overall, a lot of drugs, but know the mechanisms. Go back to my learning objectives. It's very clear. You should be able to fill out a study guide based on the learning objectives. I've pointed out the things in the tables that are important. Also, go back to that main table that has all the plus signs and up and down arrows. Once you've looked at the drugs and come back and say, okay, it makes sense. If that prolongs the QT, that would also increase the effective refractory period, put them at risk of torsades. You should be able to think through some of those mechanisms as well. So I'm here to help before the exam. Let me know if you want to come and meet. I have a new office on the 5th floor, so come and check out my new digs. But I will be around all week and next week if you want to come in and talk more. Sometimes it just helps to think out the mechanisms. So I have my evals here. I can't stress to you how important these are to us and our promotion process as we're here. So I'm just gonna, I don't even know if I can touch them. How about I'll have you all pass those out. I don't think I'm supposed to touch them. But thank you guys for being so attentive and playing along, and let me know how I can help you in the next week. Yes, I'll wait for you. Which one is it? The last party. Yes. Monday. Okay. What I'm gonna do, I'll go do it right now. Right outside. I'm gonna open up the window for upload. So just open the simplify and it should send. If it doesn't, shoot me an email. But I'll just go ahead and do that. Okay. Yeah, you're welcome.
you're the one that's